Hello, Ajay sir.
एक बार डेमो चेक कर ले।
Rahul, we can do a demo check here.
28.
Sure, sir. Request you to on your video. Yeah, great.
Yeah.
Ajay sir, once you are ready, sir, we can start with the meeting in another 2 minutes, sir.
Okay.
Okay.
I'm audible, है ना? I'm audible?
Yes, sir.
Fine. So we'll start in another 3 minutes, okay?
Okay, sir. Sure.
Rahul, tell us when we are live, okay?
Yes, sir. We can start, sir.
Right. Should I start?
Yes, sir. Please go ahead, sir.
So, a very good evening to all. Myself, Dr. Ajay Gupta. I am Technical Director in the Department of Hematology and Immunopathology at the National Reference Lab, Dr. Lal Path Lab. And today, we are having a panel discussion on varied themes of systemic autoimmune disease like myositis, rheumatoid arthritis, Sjogren's syndrome, and SLE. Dr. Lal Path Lab last year in 2022 launched the Center for Excellence in the Diagnosis of Autoimmunity. And since then, it's almost 1 year that we have completed our Center for Excellence. The Center for Excellence includes battery of techniques, some of the gold standard techniques, more than one techniques, then best of the turnaround time, then best of the quality assurance in terms of external and both internal quality assurance, and we are very much inclined towards the technical sessions and one-to-one clinical connect and prompt query resolutions. So today we have some of the very, very eminent rheumatologists of India. I would like to introduce first Dr. Malviya sir. Sir is Senior Consultant Rheumatology and Head of Department at Indian Spinal Injury Center. Sir has 40 years of experience as consultant rheumatologist, both at AIIMS, New Delhi, Kuwait University. His efforts saw creation, recognition, and rapid expansion of rheumatology. Rheumatology and clinical immunology got recognized both by the Medical Council of India as well as the National Board of Examination in India through his efforts. This helped in the creation of new departments and the Center for Rheumatology and Clinical Immunology in different parts of the India, like Lucknow, Chennai, Hyderabad. So we welcome you.
Thank you.
Then we will be shortly joining with Dr. Indrajit Agrawal. He's a senior consultant and head of department of rheumatology at Paras Hospital, Gurugram. We have Dr. Bimlesh Dhar Pandey with us. He's a consultant rheumatologist at Fortis Hospital, Noida. He did his MBBS from Calicut University and MD Internal Medicine from RIMS, Ranchi University, Jharkhand. He was working as senior resident in rheumatology and internal medicine at AIIMS, New Delhi. His special interest is in rheumatology emergencies and special clinical examination, UK. We're also joined by Dr. Shubha Bhalla. She's a rheumatologist at RV Hospital. Dr. Shubha did his MBBS from Medhi Institute of Medical Sciences and Research Center, Bangalore, and DNB General Medicine from Fortis Escort Hospital. Published various case studies and articles and invited speaker in various CMEs and conferences. So, sir, first of all, Dr. Malviya sir will be giving us some insights on rheumatoid arthritis.
Thank you. It's a pleasure to be invited to be a panelist at the Lal's Pathology Lab in the Center of Excellence. 1 year it has completed. And we all gather together to discuss some of the important laboratory manifestations of systemic immunoinflammatory rheumatic diseases. As Dr. Ajay Gupta has already mentioned, he has given me the task to discuss some of the laboratory tests, immunological tests, with regard to rheumatoid arthritis and their significance. I'm a clinician, but I happen to be also a laboratory person. In fact, I established the first autoimmune laboratory in India in 1968 to 1970 at AIIMS, New Delhi. So I can speak from both sides. But when I talk about rheumatoid arthritis, what I see nowadays is, I'll just take a few examples to set the agenda related to rheumatoid and its laboratory aspects. With increasing number of patients, the doctors are busy. They have huge, big lines waiting to be examined and seen. All the clinicians inside, they feel that there should be some shortcut. That the patient comes and I get a blood test, it tells us something and we made the diagnosis and we don't have to even talk to the patient. And forget about examining, that is even too much. I just look at the report, that is the diagnosis, this test has come positive. And thus dole out some treatment. Unfortunately, rheumatology being the last still intact bastion of clinical medicine. Although you may feel that this is an area where a large number of tests are being done, and yet it is a paradox that rheumatology still remains mainly a clinical subject. Therefore, my first point which I would like to convey is, if you get a patient with musculoskeletal symptoms, tests you can do, but you will do that after taking a very good clinical history and performing at least a good general musculoskeletal system examination. If you do this, make a summary. These are the possibilities after I have worked up the clinical side. And of these three possible provisional diagnoses, then you decide what investigations will confirm or refute my diagnosis. On the other hand, the patient comes to you without bothering, he or she opens the mouth, doctor, I have pain, thank you, and you order a panel of tests, which includes things which are absolutely absurd. A young woman or a child comes and in the panel it says uric acid level. I think that's almost a sin to do such things without thinking, why am I ordering this test? And therefore, from both the sides, from the side of a famous laboratory, they should be careful what they are putting in their so-called panels. And from the side of the treating clinician, why is he ordering a certain test when, for example, I just took uric acid. A young woman in reproductive age or a child, uric acid has absolutely no significance for any disease. And then if you still include that in the package and you look at it and say, oh, uric acid, it should be 5, it is 5.2, therefore you have this disease. That is what I am afraid I don't appreciate. And I will like you to learn that this is where misuse of laboratory is going on. And it is sad that since the COVID pandemic, people, especially the general population, has become very, very aware of different type of tests. And you now what happens is on telephone, they will tell you, doc, my D-dimer is high. And they expect me to, oh, acha, that's what you have. And you know what my answer is? Arey bhai, what is that? I have never heard of it. I have no idea. They get shocked. Now you understand what I'm talking about. By doing tests of all types which have some meaning in certain diseases, in certain situations, but making them part of the panel, the whole thing gets totally confused. And patient is spending thousands of rupees. The doctor is looking at it and diagnosing things which don't even exist anywhere. And then referring the patient to the specialist that this patient has ANCA positive. अरे ANCA positive क्यों कराया ANCA का टेस्ट? ANCA positive डॉक्टर मालविया. पेशेंट कम्स भाई आपको तकलीफ क्या है? पॉजिटिव रिजल्ट है सर. नहीं हुआ क्या है? हमको एक बार हेडेक हुआ था. कितने दिन का हेडेक था? अब कुछ दिन तक चल गया था. क्या साइनस वाइनस हुआ है? हाँ पहले भी था, हमने साइनस का ऑपरेशन भी कराया है कई बार. लो, that's the history. And headache is leading them to some type of vasculitis where ANCA is of no importance. And yet it is being done because vasculitis nikal hai. Now this is what is going on, and that is bothering us rheumatologists very much, especially because we still remain clinicians. Now, exactly the same thing is happening in rheumatoid arthritis. If you look at rheumatoid, it is one of the easiest diagnoses to make if you have spent even 6 weeks in a rheumatology clinic anywhere. Simple distribution of the joints, what we call the pattern of joint involvement. In fact, rheumatology is a strongly clinical subject. And what we do is we are pattern recognizers. We recognize the pattern in which the organs are affected or joints are affected or muscles are affected or bones are affected. Rheumatoid pattern is such a classical pattern that one little look at the patient and the patient's diagnosis comes up. Once you have made the diagnosis, you also write down 2 or 3 differential diagnoses. 2 questions will tell you it looks like lupus, but it cannot be lupus. Come in, join us. Your seat is right there. Please. So I was saying that we are pattern recognizers in rheumatology. Once we see the patient, a simple history, And in history also, I will tell you, it's so simple. Really, the patient has musculoskeletal system disease, which is inflammatory, or it is not inflammatory. So simple. And there are two simple questions in clinical that we can discuss. We ask that, oh, it looks like inflammatory. Patient is stiff in the morning. This stiffness improves on movement. Simple thing. If the patient has systemic, several joints are affected, there is inflammatory. By clinical discussion and on examination, then you say, what test should I do? Never order a panel. Never order a panel of arthritis test. Never order a package. Order pointed test. What am I looking for? I'm looking for, is it inflammatory or not? So I will order a C-reactive protein. I will order ESR, CRP and ESR. What else will I order? You know, CBC is a simple thing. Hemoglobin, how much has been affected? What is the white count? Now, you will say the white count. What is the significance? In rheumatology, it is so important. You will diagnose an inflammatory systemic disease. If the white count is high, it goes towards what we call systemic vasculitis. If the white count is towards the lower side, we go towards connective tissue disease like lupus. If the white count is near normal, likely to be rheumatoid. So simple. Similarly, why do we do CBC? Simple CBC. Blood count, white cell, platelet, debris cell, and total count, and hemoglobin. Platelet count, everyone in medicine will look at high platelet count. Sorry, low platelet count. They will worry about dengue is there, low platelet count. There is some problem. There is a systemic disease, ITP, low platelet count. We rheumatologists look at platelets because of inflammation. Inflammation causes rise in platelet. So by doing simple CBC, platelet count, white cell TLC, DLC, hemoglobin, ESR and CRP, we got most of the things that what we need. Then, because the patient has about 4 or 5 joints, small joints in the periphery, we say, and there is a history that it is stiff in the morning, we make a diagnosis of likely to be rheumatoid, which is the commonest. And we also think of some mimics of rheumatoid, and we will say, okay, let us get some markers of rheumatoid arthritis. Remember, when I talk of markers, we will discuss later and tell you these markers can be double-edged sword. But with this kind of background, where patient has an inflammatory disease in the joints, in the periphery, and the joints are affected both in the hands and feet, and the patient shows morning stiffness indicative of that there is inflammation, and the CBC shows high ESR and CRP, we are almost there that this patient is suffering from an inflammatory rheumatic disease, commonest being rheumatoid arthritis, likely rheumatoid, but then we will take a little more systemic history. Extra-articular manifestations will guide us, whether it is rheumatoid or one of the mimics of rheumatoid, which my colleagues will discuss very soon. Now, when we reach that stage, then comes, what marker are you talking about? Whenever we talk of a marker, biological marker for a disease, and rheumatoid is not any secret, we do rheumatoid factor. And please never call it RA factor. There's no A in it. It is rheumatoid factor, not RA. It is RF, rheumatoid factor. And any laboratory which writes down RA factor, never go to that lab, because they don't even know what they're talking about. The second test is anti-CCP antibody, which in short is called ACPA. And when a laboratory converts it into testing, they make artificial antigens and they start calling it anti-citrulinated. I'm not going in detail, but we are talking about ACPA. ACPA has high sensitivity and specificity. So we will do these 2 tests. And then after taking the history, physical and all that, if it is high titer, we will say, well, it looks like that you have seropositive rheumatoid. If it's negative, seronegative Then we will talk about several other possibilities, which my colleagues are going to discuss shortly. That's where I will stop as far as rheumatoid is concerned. I have been asked to talk about one other point, which I think during discussion I will do.
Thank you so much for your very, very lucid insights on rheumatoid arthritis. We'll take a couple of quick questions before I move to Dr. Indrajit Agrawal. So there is curiosity among the patients and especially among the physicians also. How can we diagnose rheumatoid arthritis at an early stage?
This is one of the really challenging things for rheumatologists. When rheumatoid is starting, it seems that when the patient is coming to the clinic with swollen joints, there has already been, the trigger has been set on at least 5 to 8 years beforehand. Something has happened in the body several years earlier, which has triggered a cascade of immunological events, which has finally led to now clinical disease, which is visible. The question asked by Dr. Gupta is, how do we diagnose at the early stage? What we call early actually is not early, but for a clinician, it is early because no joints are swollen. Patient comes with vague symptoms, musculoskeletal manifestation by way of some stiffness in certain parts, some muscular pains in certain parts, some vague running pains in the distal parts of the extremities. And the patient says, I don't feel well, doctor. And that is the stage when we will like to at least be sure that it's not the onset of the clinical aspect of rheumatoid. Because rheumatoid, as I said, subclinical starts several years earlier. But when the patient has these vague symptoms of pain, what we call arthralgia suspicious of arthritis. That's the exact word that has been coined internationally nowadays. Arthralgia suspicious of arthritis. If the patient comes in this stage, we have to take very good history of, again, the same thing. How do you feel in the morning? If there is symptom which is more prominent in morning and starts to improve after gentle movements over a period of time, that goes in favor that the body is already feeling inflammation somewhere in the body. Once that the patient admits to, then you say, oh, it looks like inflammatory in nature. Then what you look into is something very interesting, and I will like to pay attention to this. Although rheumatoid is a joint disease, but it does not start in joints. It starts in tendons and tendon sheaths. And therefore, the flexor tendons of the hands, extensor tendons of the forearms, these are the areas. And in the feet, look into tendonitis. Now, you will say, clinically, how do we diagnose tendonitis? And that's where, if you take the history, there is some type of morning stiffness, not really in the joints, but in the muscles and in the body. And the patient says, I feel better after movement. You ask your colleague, ultrasonic examination of the musculoskeletal system. They come in place right at this stage. They have very important place in the diagnosis of early rheumatoid arthritis when the joints are not affected and there is no clear-cut synovitis. So many cases we are seeing nowadays, such a patient with vague symptoms and morning stiffness comes, we feel that is inflammatory in nature. Some good fellow, some colleague, doctor has already done ESR and CRP. It seems to be slightly elevated. You ask your colleague, ultrasonic examination person who knows musculoskeletal ultrasound, they will look into hands, forearms, and distal leg. They will do the ultrasound and they will, oh, Dr. Saab, the patient has frank tenosynovitis. And there are inflammation occasionally in these places, and even some synovial proliferation in tendon sheath is starting. Thank you, my dear colleague. That is the first symptom of rheumatoid arthritis. I will like to order 2 simple tests besides, of course, CBC, ESR, and CRP. And those 2 tests will be rheumatoid factor and ACPA test. These 2 tests, if they come high titers, I will confirm that the patient has already started a seropositive rheumatoid arthritis, although the joints may not be affected, but this is the beginning. What do we do with such a case? Do we start treatment? Yes. Already objective manifestations are present, and that's where I will be very aggressive in treatment. You know, some people say, hey, itna chota sa early case, why do you? No, this is the place where I will, you know what I will do? I will give pulse steroid therapy. Then I will rapidly build upon methotrexate, hydroxychloroquine, and intermittent steroid till the whole stenosynovitis disappears. Because this is the phase when the heat of inflammation, autoinflammation, is at the peak. If we can stop it 50 years from now, the patient will still remain totally normal. That's my answer to early diagnosis of rheumatoid arthritis in the present scenario.
So you are very well explained about the biomarkers like RF and anti-CCP or APCA. We have seen a new marker which is coming up, that is anti-MCV, mutated cellulated vimentin.
Mutated citrulline vimentin happens to be, if I tell you, anti-citrulline protein antibodies. Actually, you can take any protein on earth and remove arginine and place citrulline in place. It becomes citrulinated. So what is citrulinated protein? It is substitution of arginine by citrulline. So you can make artificially any protein you take in the laboratory and convert it into citrulline. But citrulination also occurs in the bronchial mucosa in patients, those who smoke, or those persons whose gum is unhealthy and it has porphyromonas type of infection. The protein, body's own protein, get changed into citrulinated protein. Now, when the antibodies start making against this abnormal protein, because they're not seen in the body, so once this change occurs in the protein, immune system recognizes it as something not self. And anything which is not self, the body starts making antibody. These antibodies will be anti-citrulinated protein antibodies. In the beginning stages, before the rheumatoid becomes clinically apparent, this antibody will react with a few, just 3 or 4 different types of citrulinated proteins. But as the disease nears clinically apparent, becoming clinically apparent, more and more reactive antibodies start coming. And then vimentin, and I have written down the whole name. There is 3N protein, high mobility group box protein, anti-citrulinated peptide protein, anti-mutilated citrulinated vimentin, anti-CARP antibodies, rheumatoid factor, which happens to be anti-FC portion of IgG antibody. So these are different antibodies. As the patient nears clinical onset of disease, the number of antibodies reactive with different and increasing type of citrulinated protein increases. There have been since 2006 some study that the name is mutated citrulinated vimentin. And there is pros and cons. The first paper said it is highly specific. If this antibody can be detected, that means from preclinical stage, rheumatoid is now changing over to clinical stage. Second paper came, it is absolutely wrong. It has no significance. Anti-citrulinated protein antibody or ACPA itself is more than sufficient and much more sensitive and specific. There is no need to do it. 2009 was a Chinese paper which went into 200 some odd patients with rheumatoid. This repeated, it's very highly specific and it should be made as a part of the panel of antibodies. The latest came in 2014. Forget about it. Don't do it. It is no more better than simple ACPA antibodies. So all these antibodies will come and go, but the test of time withstood by ACPA and rheumatoid factor. So let us stick to these two. These fancy antibodies come sometimes in future, but if they are better than this, then we will talk about it. And I will mention anti-CAR-P antibodies. So much noise about anti-CAR-P, but till today, it has not been included in the routine panel of antibodies. So let us wait till it is really proven that it will help a clinician make a diagnosis. Till that, we will keep it aside.
One thing about drug resistance, UTI is more common among the patients having rheumatoid arthritis.
I tried to read such a paper. Unfortunately, there is no evidence for it.
This was raised by one of my colleagues who is in internal medicine. He asked me any of the reasons, and he told me that Proteus mirabilis is the most important.
Now, I went through the literature. I tried to figure out that somebody has asked. I might have missed the paper, but I couldn't find that there is increased UTI. Of course, there are certain drugs. If you give them, then there is chance of increased infection. And whenever we talk of increased infection, UTI is one of the important ones. So if you start with biologicals and rituximab, or if there is increased incidence of infection, including even JAK inhibitors, then UTI will be one of the common infections, besides pneumonia and zoster and others. So I will not say it is something specific for rheumatoid. It is the suppression of the immune system if you use immunosuppression. By the way, all the drugs that we use are not immunosuppressive. They are immunomodulators. There are few of them that are immunosuppressive. Rituximab happens to be an immunosuppressive. Methotrexate is immunomodulator and not immunosuppressive.
Right. Thank you, sir. Now we move to Dr. Indrajit Agarwal, sir. Sir is Head of Department of Rheumatology at Paras Hospital, Gurgaon. And we'd like to have some insights on lupus from your side, sir.
Thank you. Well, lupus is an autoimmune condition, we all know, and it has many manifestations. So some patients who are in the early stages in their early childhood, they can have fever, joint pains, mucosal ulcers, then low platelet count, low hemoglobin, and all sorts of other things, including renal dysfunction, can occur. Similarly, in the young adults, it presents with multitude of symptoms, certain clinical parameters, some lab parameters, and some autoimmune parameters. Well, it is something of a disease where anything and everything can be possibly seen to. And I'm sure that all of us, who have done rheumatology for many years, we would have come across yet another type of presentation. But having said that, the most common ones will be obviously malar rash, a skin manifestation, your joints manifestation, oral or mucocutaneous manifestations. Some patients will have problems like DVT, PEs due to anticardiolipin, antiphospholipid antibodies. So renal dysfunctions are very common. So these are all different types.
Right.
Patients can present, but we need to be very careful because after all, still many patients in our country, they are not diagnosed early. Sometimes the mean time of diagnosis sometimes can run into months, sometimes can be years because the doctor in the smaller areas is not aware of it.
On that note, sir, very rightly, I'm forgetting where I had read, as Dr. Indrajit told, and in Indian scenario, we are all people are not living in tier 2, tier 3 cities, and an estimated time of diagnosis for systemic autoimmune disease from the day of onset of the symptom for the final diagnosis was 2.5 years.
You are right. There is some paper.
I'm forgetting. 2.5 साल लगते हैं एक patient को diagnose होने में. So I think that is the agony which the patient is facing. So let's have some questions on lupus, sir. We all know that ANA is a basic screening tool and has been given an entry criteria in the classification, 2019 classification for lupus. How do you see this and the role of ANA as a screening tool in the autoimmune disorders?
Well, in 2019, this came as an entry criteria. Well, wherein we know that about 90+% of the patient who suffers with lupus, they will have ANA positive. If you do by different types, either EIA or you do with immunofluorescence, so 90 and above of the patient will have. So still, if you're a purist, 10% of the patient still will escape from ANA as an entry criteria. But having said that, 90% if you are to deal with it, and I think probably, it has been discussed immensely in rheumatology, among the rheumatologists, among various specialists. And I'm happy to accept this. Initially, it was a bit challenging, but later on. Well, there are going to be so many biomarkers which will be available in the future that may look after those 10% of the patient who will still escape from ANA. But it is a nice test, and immunofluorescent test should be the criteria. But having said that, it is slightly costly. So EIA method is equally good because it has got fairly good specificity and sensitivity. Well, whether it is a screening tool in autoimmune diseases, I will not accept this because autoimmune disease is huge. Probably thousands and thousands of different types of disorder. Some has got genetic links, some has got, some metabolites, which then trigger off autoimmune diseases, some viral thing. So I think just to do an ANA and thinking that probably we are ruling out all the autoimmune disorders, it is probably a bit naive.
Right, so absolutely. And not many of the diseases are also, we will get ANA negative despite of the fact that the patient might be having systemic autoimmune disease.
This stands true for connective tissue disease. It is a screening tool for connective tissue.
Correct,
Yes,
correct.
but not autoimmune.
Not autoimmune.
Right,
Connective
right.
tissue disease, yes.
Right. So do you recommend a panel of tests helping in the determination of prognosis of patients under the treatment for SLE? If yes, which of these tests should be there under this panel? Follow-up cases of SLE.
Dr. Malviya just now said that, the most important thing is proper history taking, good physical examination, and then you will obviously, of course, come to a conclusion that the patient has got SLE, and then you will order for battery of investigation that you like to have. So yes, if you ought to recommend panel of tests helping in determining the prognosis, I would certainly go for the history, whether the patient has got prolonged fever, joint pain, weight loss, some things like anemia, thrombocytopenia, all sorts of things which will be taken into equation. Then I will completely start with a small test like blood counts, platelet counts, do a ANA test. We'll do a dsDNA. We'll check for the complement C3, C4. We'll do a urine analysis. We do a echo to rule out any possibility of cardiac problems and manifesting as lupus. So I think probably that will be my way to go about it. First, foremost, good history followed by good clinical examination. Then you do simple test, which will give you most of the answers, like, pulse, heart rate, blood pressure, pedal edema, right. Everything will add to that. And eventually you will do the tests. Right.
In fact, this question which I'm asking, I think this is open to all panelists. It's my dilemma also when we report dsDNA, sir. So in a fully monitored or maybe a patient having in line with the prognosis for SLE, dsDNA level comes negative at some time of the treatment, or it remains equivocal, or it remains positive. Sir, your experience.
I will really like to spend a little time on this because Indian Immunologist Society called me to discuss ANA because they were very confused what's happening with ANA. I will start with one thing. If we go to Dallas Heart Study, why am I talking of heart? Because that was a community study. They were studying the possibility of heart disease in normal people in a community in Dallas. And they had 20,000 persons, normal people. And when they started doing, the rheumatologist said, that's the best time. Can you give me a little sample? And what they did was, did all the antibodies. Of course, the patient had to give consent that you can do that. That they had taken. Now, in Dallas Heart Study, it was stunning. And this was known since 1993 when Eng Tan did in California, that normal people, normal persons in population, 30% are ANA positive. Now, this I have been teaching and teaching and teaching. 2006, it was final that everyone should know ANA is positive in normal people up to 30%. To be very precise, it's 28 point some percent, near 30%. Once you know that, then the issue comes. What is the positivity rate of ANA in lupus? What, where else can you go except take the best drug trial that has been conducted on lupus, which brought in a new drug called belimumab. So let us go back. Belimumab has been cleared by FDA for treatment in systemic lupus. So you can't argue. They were all lupus patients. All the experts in the world, from Philippines to California, all the best of best lupus patients, doctors, they diagnosed the patient and they were taken in this study. And do you know, in the first belimumab trial, it failed. The drug has failed. What to do? Look at, can we reanalyze? There's something wrong. How many patients have lupus? They're all wonderful. ANA positive? My God, 27% ANA negative. How can they be lupus?
Right.
Diagnosed by none other than Wallace and Tan and all the top bosses in England and Europe and Philippines, and all lupus are definite lupus. 27% ANA negative. Can we then see what is the effect of belimumab in these two groups? Beautiful. ANA positive effect of belimumab, ANA negative effect of belimumab. Phase 3 trial, separate them out. ANA negative lupus doesn't respond. ANA positive lupus, belimumab is the drug of choice. What does it teach us? It is the same disease, but there are what we call endotypes. Even rheumatoid is not one disease. I have submitted this paper, hopefully it will get published. Endotypes of lupus is to be looked into. That determines which drug will work. And that, by the way, is the origin of why Euler brought in ANA positivity so that, and you know, these are not for diagnosis. The criteria, classification, not for diagnosis, they are for drug trials. So now to ensure that the drugs that itne mehnat ke baad somebody comes up with a molecule, but test it in a proper way. You are testing it in a negative lupus and you are saying it is ineffective. Asli lupus mein NA positive hai, wo wala leke dekho. That will come positive. So now this is where we are, and that's why when Euler came up with the new, that was the reason that they have included ANA as a criteria to entry criteria.
But you know, they chose a very low titers, 1:80.
Yeah.
They did not go the-
And that I was just coming to.
Right.
For clinical, it is 1 in 160.
160
And then 1 in 80 for trial.
for trials.
Okay, 1 in 80, 1 in 160. And whosoever is listening, please listen to this very carefully. When we have the pattern which Dr. Gupta will tell us, 29 patterns and 4 of them, if they are present, ensure that they are totally normal people, because that pattern of anti-nuclear positivity occurs only in normal people. Moreover, DFR,
DFS 70.
DFS 70,
Then spine speckled.
and then spine speckled if it's present, rule out lupus, rule out any disease. They will never get in future, you can predict they will never get any connective tissue disease in future because ANA is strongly positive. But which subset? DFS 70. So ANA has become more complicated. It should be realized. And therefore, by closed eyes, just asking for ANA and it comes positive, oh, lupus, please don't do that. It's not that easy. You will still, as Dr. Indrajit Agarwal just mentioned, have to be a clinician. You will have to get a good clinical history and physical examination before you make.
Well, this is something which is very interesting, that all over the world, the referral to the rheumatologist has increased tremendously because of the ANA being sent out.
The whole day we are doing this. ANA positive, aa gaya.
Yeah, the DSDNA level, again, it is quite interesting that, many a times the patient will correlate. But then, as we know that almost maybe about 40 or near about that percent may not correlate so well with DSDNA. Okay. And I have seen patients, who are perfectly fine, clinically. They don't have any kind of active lupus. And if you check their DSDNA, that are very strongly positive, which I'm talking about my UK experience, because in our country here, we may not at times, do the complement levels and DSDNA. We check out, the DSDNA is still raised, again, you think that whether this patient is going to have activity soon or not, and you have worked it out again, maybe have called for a review. The patient has still the same, but no activity.
I followed the
Two points up इसी के संदर्भ में, so that we don't lose it. There is something very interesting. And now we know that in antinuclear antibody, if we take ENAs and DNA included, there are certain antibodies, they never fluctuate. They remain steady. On the other hand, anti-DSDNA antibody is supposed to fluctuate. Why does it happen? Now, the answer has come very recently that there are two types of plasma cells. The long-lived hidden plasma cells. All the antinuclear are made by long-lived plasma cells, so they will not change unless we have ibinotuzumab, the new drug which has come in to kill all the B cells. Then even they are hiding somewhere in crevices of bone marrow, even they will be killed. But till then, rituximab doesn't touch B cells of that variety. Long-lived plasma cells and B cells are not touched. The dsDNA seems to be produced by short-lived plasma cells, so it fluctuates with the disease activity to some extent. In what he mentioned, that dsDNA does not correlate, and we all see it. And there, I think even in abroad, you ask them, they will say, happens here also. I think what's happening is, and a laboratory person can confirm it, there is a little bit of single-stranded DNA, degeneration, denaturation of double-stranded, and that is giving a false positive test. Because single-stranded DNA is present in everyone. So that gives
I had followed 20 cases who were absolutely diagnosed with lupus. And after 3 months, their dsDNA levels by ELISA used to come to them. And I followed them. And the last title, patient used to be very, very inclusive. Sir, क्या है मेरा फटाफट बता दो क्या क्या है मेरे ट्रीटमेंट डॉक्टर साहब को बताना डॉक्टर साहब बहुत उसी दवाई देंगे उसी बेस पे the last after maybe a year or so their results were equivocal, neither positive or neither negative, but it came down from 200 to 50 and it remained equivocal but not on the negative side.
Exactly.
What I can
This is a problem.
Yeah, this is exactly what we should see.
Yeah.
But, by and large, we should see, but, some patients will not. But, it is a good tool, if you are able to do that, in your patient. But then, there is going to be still some subset of patients who will have activity. And if you check dsDNA and complement level, they will not fluctuate the way you want,
Right. So how can we diagnose lupus nephritis at early stage?
Well, once again, clinical examination, history taking. The simple clue, like, if you ask the patient that what is happening, are you feeling weak? Or they themselves will say that, because of, I have to go for urination, black colored urine or whatever, hematuria, frothy urine. So all these kind of things, leg swelling, periorbital swelling, these things will definitely be told by the patient. Then you examine blood pressure, pulse, check for anemia, check for all that. So that will be contributory. But yes, lupus nephritis, the gold standard, you should do obviously, check for blood count, kidney function test. You will do liver function as well as you will do the urine creatinine and albumin ratio spot test, 24-hour urine collection. All these things has to be done. But the gold standard will be renal biopsy. And once that is the problem which we face immensely in our country here, that the renal biopsy, again, it is a costly proposition, it is an invasive procedure, and the cost is the main reason maybe that, in my practice, I don't want to get involved into that kind of, equation wherein the patient has to spend so much. So, but that gold standard is still your biopsy. Right?
So thank you, sir. And now we move on to a very, very tricky topic, myositis, and that will be dealt by Dr. Bimnesh Darbani.
So myositis happens to be actually very, very rare disease. And the challenge is, can we pick them early, because it's a rare disease and many times patients are lost in the community about the problem that they have. But this is very, very clinical that about this disease is when the patient would present you where they have profound weakness. The basic would be, I can't get out of my chair. I can't do activities, what I was able to do. I can't raise my hand, comb hairs. I can't write for some more than a minute or so, maybe 10 minutes. Some of these patients may also have other clinical features, and that would be skin manifestations. And this is how they present. Profound weakness, inability to get out of the bed is what they would say. I can't get out of my chair. I can't climb stairs. I can't get down of late. They are getting, from bad to worse. But the important thing that we have to understand about myositis is that it can be seen in the pediatric age group, it can be seen in the young, and it can be seen in some say 35, 40 years back. This disease was very well defined, and they were sub-classified into different domains, say, with the skin manifestation, with only muscle manifestation, with the pediatric population. And this is how the world moved for some time, where perhaps it was almost necessity to make a diagnosis other than the blood, markers, which was basically muscle enzyme markers, CPK, LDH, L2S. This is how the world moved for some time, and it did work well. But over time, we got more information. That is just not one disease, which we call as dermatomyositis or polymyositis erstwhile. They are now labeled as inflammatory idiopathic myositis, and it is actually a big group or chunk of muscle diseases which are now being subclassified with different types of antibodies which are actually present with this, and they govern this disease, and they have been very well established that there are diseases which are myositis specific, and there are certain diseases where you have an overlap, where a patient of a lupus may have a myositis, so you can say overlap syndrome, so myositis associated. And with this, the world has moved. If you have seen few trials that came in early 2000, so they were having only one or two myositis, myositis specific antibodies which they used, and later on they identified that it was quite not sufficient, and then they subclassified it. And interestingly, there is a group of disease called as necrotizing myositis. There's a group of disease which is what we commonly call as dermatomyositis, where skin is profoundly affected. But there's a group of disease where lungs are also equally affected. So you can have an overlap between a lung and a skin disease, or predominantly a skin disease. You can have cancer-associated myositis, which is very, very important. And if you again look into this population, I will just try to give an example, malignancy-associated myositis. So if someone comes with myositis and is in 60s, we definitely look forward to see is there any malignancy for not only at that point of time, maybe over years, maybe after 1 year or 2 years, to look for a malignancy, because a good number of patients may have underneath, a malignancy, which is actually a driver, and you have an antibody form. So quite amazing at this point of time, because more and more information is actually coming. And Professor Malvi has taken enough and more classes on this topic of understanding myositis specific and myositis associated. So if wherever I go wrong, he has to correct me, and this is what he, as a teacher, he would be doing it. So a few days back, he was saying, statin is HMG CoA reductase. Even if you have not taken at any point of time, statin still have a myositis which is governed by HMG CoA reductase antibody formation. So what is happening? So you have a de novo, formation of antibodies, and that causes necrotizing myositis. And if you don't treat them early, if you don't diagnose them early, how do you treat them? You have to be quite aggressive. If you have an MDA5 associated, what do? You have to make a quick diagnosis. You can't say CPK LDH is high, but in this disease, you may have no CPK LDH elevation. So it is just not a general rule. But in most of the myositis, you have the muscle enzymes which are elevated. And certain diseases they don't give you time. And one of them is necrotizing myositis, which probably was the typical polymyositis erstwhile. People have now challenged the diagnosis of a word called polymyositis, that just make those small entities and say necrotizing myositis, label them the anti-synthetase antibody associated myositis, or skin associated classical dermatomyositis. And then you have a inclusion body myositis. So it goes on.
Thank you, sir. And just a few questions. So you had already talked about, now this is an upcoming biomarker, HMG-CR. Can we have that slide on that, sir? We will be at Dr. Lal Path Lab, National Reference Lab, will be launching this test soon, maybe in a week or 10 days. How do you see this test in terms of diagnosis?
So to a clinician, if I get a CPK which is as high as say 15,000 or 20,000, I start thinking of necrotizing myositis. This is how I would begin with. When you look forward to see necrotizing myositis, so you can be aided by your MRIs, where you can see profound, muscle edema, MRI sequences of these patients. And this is actually going to help you, but that everything is clinical. When do you do, and when you do not do certain tests is very, very important. But this is going to help. Sometime back we had only 8 biomarkers for the myositis panel, but then it is getting expanded. But myositis specific antibody are a different group and should not be clubbed with myositis associated. Those clubbings do not help. And one can actually ask also a specific test, the way Professor Malviya said. If I want anti-CCP, I don't want to get confused with anti-biomentin. I just want anti-CCP. So if I want, I think of it as being necrotizing myositis, I may ask anti-SRP or anti-HMG co-reductase antibody. So that's it.
So, sir, when we talk about myositis specific and associated antibodies, do they have a role in the prognosis of idiopathic inflammatory myopathy?
Yes, definitely. So when you have a necrotizing myositis and you can actually define it, you also sometimes choose your therapies. For example, in necrotizing myositis, if you have an anti-SRP positive, so the type of drug that you may use upfront is now rituximab. While if you have HMG co-reductase, the first drug that you have to use is immunoglobulins, IVIG. So this is how the distinction has started. If you go to say MDA5, you have to be, you may require a larger dose of, or combination therapy, which may include IVIG, may include rituximab, may include all steroids.
And the new one is JAK
inhibitors. But if you have an anti-MI2, what do you do? Give steroids, and still you will get very good. The best clinical, is with MI2, where you get classical dermatomyositis. All the skin is involved. You can take good pictures, show it to the students, but steroids give an excellent result. So this is how it is. If you have in pediatric population, NXP2 associated antibody, they get a huge amount of calcinosis. If you don't treat them aggressively, the child has got a lot of calcinosis all over the body. But the same antibody in elderly is associated with malignancy. You have to TIF gamma and NXP2. You go on looking for malignancy here or there. Your mind cannot go away from that idea of malignancy. And if you have an anti-synthetase, you look off the lungs, go on for lung. that is where your pulmonologist would send you a patient, and you have to think that not all the rapidly progressive ILDs, you have to be quite, clinically oriented to identify myositis in this.
So, as a lab, and we have got a panel, an extended myositis panel in which we have clubbed the specific and the associated antibodies. So, do you see this panel of myositis antibodies as a first line of investigation in a patient who you seriously think that he might be having some sort of?
It's a very good idea. It takes away the turnaround time, because with one sample you get everything done. And the second question that everyone has to ask, is it cost effective to the patient? Because in India, we all pay from our pocket, right? So whatever we do, it should be cost effective to the patient, and it actually helps in reducing the turnaround time. That is the practical aspect of getting.
I have a few points. He mentioned it very, very nicely. The most important point to remember is that in inflammatory muscle disease, these myositis specific and myositis associated antibodies are present only in pockets. This must be remembered. So when you send and say, I didn't get any antibodies, are all negative. Yes, 60% is negative. And the 60% that is negative is also happens to be more often related to some underlying malignancy. This has to be remembered. Regarding the antibody, they really help us. If MI2 has come, nothing to worry, methotrexate, a little bit of steroid, and person is going to go right. HMG-CR, the antibodies against this receptor with which statin also reacts, but it's not necessary. I mean, that receptor is a protein. So it has become now antigenic, to uske against antibody ban rahi. इसको statin तो दिया नहीं, कैसे बन भाई statin से क्या मतलब? This is the protein which is the receptor. Many antibodies are formed against receptor. The name is there, statin receptor. So why worry? But the moment you have this necrotizing type, HMG here and dusra SRC, my God, you have to rush with IVIG and rituximab and high dose this, that, and plasmapheresis, because they will die with massive necrosis in the muscles, which on pathology will show nothing except degenerating fibers. Then you come to a person who doesn't have anything in the muscles, and yet the patient is basic. Scadum, clinically myopathic, muscles are normal. You put just look at the stethoscope, it's all full of interstitial lung disease. Arey bhai, you rush over, this is Jovan and non-Jovan. Anti-synthetase, Jovan and non-Jovan. And the moment you see that, then your treatment entirely goes towards treating interstitial lung disease. But if nothing, all antibodies are negative, or TIF gamma, or NXP2, don't wait. Go for cancer test. Go for PET scan straight away. There may be one lymph node which is slightly enlarged in the hilum, and you can catch a malignancy at that stage. This is how we use, and I tell you, of all the antibodies that we have discussed till now, to me, the panel of myositis specific and myositis associated are probably the most important. And now, slowly over a period of time, because of the mess in which anti-nuclear has gone, I feel that's the worst test that ever was. Unless you tell me the likelihood ratio, I think ANA has gone to
I've seen so many cases of anti-synthetase syndrome in which JO1 is positive and ANA is negative. ANA was negative.
ANA has to be negative. Of course,
That is a different district.
You know, this is what the pulmonologists have missed all this in the early stage. It is Apna Rohit Agarwal who has brought whole thing back. He being from rheumatology, going in this area, usne kaha, the pulmonologists get aside. You are wasting your time here. You are not really catching the thing which we rheumatologists will teach you. He says, go to ICU before going home in the evening. When you have finished your round, one round to ICU. How many of ILD? There are myositis specific antibody. Get it done. Half of them are our area. We will treat them. Pulmonologists give only antifibrotic.
So that is also a, sorry, like, it is quite interesting that, some of the patients may have, say, start with lupus and then they may again, once you treat them, they are doing fine. And all of a sudden they may develop some other autoimmune diseases. And that kind of crossover that you may like to see. So, it is very difficult to say that, okay, this patient has got this and it will remain the way it is. No, it may change. But
So now we shall be moving.
As
to
an
Dr.
example,
Shubha.
I had a patient with rheumatoid and in consultation with rheumatoid, while talking with rheumatoid, 3 years I treated her as rheumatoid, seropositive rheumatoid, doing wonderfully well. A doctor, nephrologist calls me from Rohtak, your patient with all the notes, sir, this rheumatoid, suddenly she has hematuria and she is all bloated and protein in the urine, but full of red cells. And now she is having nasal bleed and lungs is full. She has ANCA positive, she has vaginous
Right.
rheumatoid conversion. Is what she was just mentioning.
So thank you, sir. Now we move to Dr. Shubha. She will be throwing some light on Sjogren's syndrome.
So first and foremost, on behalf of all of us, I would like to congratulate Lal Batra for completing 1 year of Center of Excellence. Now, coming to Sjogren's syndrome, it's one of the most prevalent autoimmune disease, second most common to rheumatoid arthritis. And it is characterized by lymphocytic infiltration of the predominantly of the exocrine glands. Now, it is female predominant, and so the ratio, male is to female ratio, is around 18:1. And in India, it usually affects female in their late 30s, whereas in Western population, it affects females in their 5th or 6th decade of life. So basically, it presents with the classic triad that was earlier described was Zika symptom, that is keratoconjunctivitis Zika, with xerostomia and glandular enlargement. However, there is much more to Sjogren's syndrome than that. And coming to diagnosis, as all of us, have been saying, nothing beats history. History is the most important thing to come to the diagnosis. Like in SLE, Dr. Indrajit said, even in Sjogren's syndrome, sometimes it takes years for a patient to get diagnosed, especially if your doctor is not a rheumatologist, because the symptoms are so variable and wide and non-specific. Now, around 40% of patients would come to us with classic symptoms of Zika symptom and fatigue and arthralgias, but most of them don't even report Zika symptom. And that is where the challenge lies. And so these patients, so we need to have high clinical suspicion to pick up these patients. So anybody who comes to us with chronic myalgias, arthralgias, we should look for Zika symptoms in them. Somebody who has non-deforming arthritis, or what we say Jacquard arthropathies, those patients also should be screened. Someone who has obviously dental caries, frequent dental caries, or premature loss of teeth, or recurrent oral candidiasis, we should look for Zika symptoms. And for that, we sometimes have to inquire indirectly by asking them whether they need to take water to swallow, dry foods, or do the patient frequently wake up in the night to drink water. Similarly, for eye, we need to ask them whether they have a gravel or sand irritation in the foreign body irritation in the eyes, and so on and so forth. Some of these patients, this is very interesting, that some of these patients would just report blurring of vision without complaining of Zika symptoms. And this is because of the fact that many of them have corneal neuropathy. And so their sensitization towards corneal damage is reduced, and these patients develop corneal abrasion and an ulceration and have permanent and may have permanent visual loss. So it's very, very imperative to pick these patients early. And having said this, it's also very important to exclude other causes of Zika symptoms in these patients, like diabetes being one of the commonest cause, hepatitis C, HIV, then we need to ask them regarding history of radiation for head and neck cancer, drug history, and so on and so forth. And even also keep in back of our heads the differential diagnosis of Sjogren's syndrome, which are sarcoidosis, IgG4 related diseases. Now, these are the glandular symptoms. These patients may also come with extraglandular manifestations, which is fatigue, arthralgias, purpuras, chronic urticarias, Raynaud's phenomena, and a plethora of systemic manifestation. An interesting fact is some of them, may for the first time present to a pulmonologist with ILD. Now that is when these anti-nuclear antibodies, ANA, comes to our aid, because the pulmonologist would go do an HRCP and then subsequently find an NSID pattern or UID pattern, NSID being the most common, and then send an autoimmune profile. And then subsequently the patient comes to us. Likewise, we know that sometimes these patients can have neurological symptoms way ahead of Zika symptoms. So they land up to a neurologist OPD. And similar way, the autoantibodies are done for, let's say, peripheral neuropathy or a demyelinating lesion, and then we get involved. So some of these patients of Sjogren's syndrome may also come to us with hypokalemic periodic paralysis for the first time because of distal tubular renal acidosis. They may also come to us with sura fractures, secondary to, again, distal tubular renal acidosis causing hypercalciuria, hypokalemia. And sometimes we pick up a patient who has history of recurrent fetal loss in her second or third trimester. This is because the patient has anti-Ro antibody, and because of that, the fetus is having recurrent congenital heart block. So the manifestation of Sjogren's it has myriad presentation. And so to further diagnose if the patient has Zika symptoms, we do the objective test to document Zika symptoms. For eye, we do Schirmer's test. For dry mouth, we have salivary flow test that we commonly do in our labs. And after that, following this, we have lab investigation. ANA is positive in 85% of patients of Sjogren's syndrome. Anti-SSA. Now, the new classification in 2016, which has been accepted by ACR and EULAR, they have removed SSB. Now, only SSA antibody is included in the classification criteria. Along with that, if either that or patient, we sometimes need to do a lip biopsy, a salivary gland biopsy. If that shows lymphocytic salivaritis with focus score of more than 1 per 4 millimeter squared, then that is also definitive of Sjogren's syndrome. And along with that, other Schirmer being positive, all these things then we can classify patient to have Sjogren's syndrome. Now, coming to the lab, I'm sorry, I digressed. So ANA is one, SSA is the other one, which is positive in 70% of cases, SSB around 30% of cases, but it's not really relevant in absence of SSA. Complement levels we also do, it's very important to see globulins in these patients because hypergamma globulinemia can basically make these patients prone to developing lymphomas. Similarly, complement levels, low CE4 levels can also, predispose these patients to risk of lymphomas. So, and it's very important to see urine for proteinuria. It's important to see electrolytes to rule out RDA, and urine also for the pH. That also gives an indication. So these are the important lab parameters that we use in Sjogren's syndrome.
We have seen one case of congenital heart disease, and that samples were sent from Ranchi, and the sample was of a 2-day-old baby, and its roll were strongly positive and then we had to recheck, 2 दिन का बच्चा है, इतना strong SSA, SSB आ रहा, then we called upon the pediatrician, then requested the sample of mother. Mother के sample आया, same था उसके अंदर, then all the investigations that the heart rate was 50. So that was a he presented with it, definitely. So couple of quick questions, Dr. Shubha. Sjogren's syndrome may coexist with other autoimmune diseases, which are the commonly associated diseases, and how can we diagnose connective tissue diseases in such cases? Do ENA profile help us?
Yes, obviously, we know that Sjogren's can be associated with rheumatoid arthritis, lupus, scleroderma can be associated with scleroderma, inflammatory myopathies, and even vasculitis, for example, granulomatous polyangiitis. And so if the patient either has clinical feature of another connective tissue disease, be it clinical or laboratory feature, and along with this has a positive autoantibody pertaining to that connective tissue disease. So then we diagnose the patient to have both the diseases coexisting.
So ANA can be negative in suspected cases of Sjogren's syndrome. So how can we overcome this dilemma?
So ANA is negative in 15% of patients. So then it's always better to get SSA and SSB antibodies done separately. And also the other thing that for SSA, SSB, so we also have an entity where ANA is negative, SSA and SSB antibody are also negative, and still patient is a defined case of Sjogren's syndrome. So in that case, so Hep 2000 cells, they have a higher concentration of anti-Rho. They are useful. And
I think nowadays most of the tests are being done on Hep 2000, right?
So what kind of monitoring is recommended in patients of Sjogren's syndrome?
Like I mentioned, we do at every follow-up, we do the CBC with acute inflammatory markers. We get we check the immunoglobulin levels. We check the renal function along with the serum electrolytes. Urine for proteinuria, we also check that. Complement levels are also checked. Then so on examination, it's very important to look for lymphadenopathy, splenomegaly in these patients, because that if it's present, it makes them prone to develop lymphomas in future. And also rheumatoid factor is very important, because if rheumatoid factor is initially positive and later on becomes negative, that's a bad prognostic factor.
So as we conclude our panel discussion from the question point of view, now the theme of myositis, rheumatoid arthritis, Sjogren's syndrome, and SLE has been beautifully presented by our eminent panelists. And we open the house for questions for the audience who have joined live with us. So I would be requesting, so the first question is, one after intramuscular injection, for how long CPK NAT remains elevated?
Very, very, very fundamental question, actually. Right. So any trauma would elevate CPK. So even exercise can elevate CPK. This is how we need to be very careful. So it is considered that if you're given an intramuscular injection for a week, you need to actually wait, because that is the intent of that, because the drug is also delivered there. That is also causing changes there. And then the question is, what was the injection that was given there? So if it is, oil-based, it creates more inflammatory changes, allows more CPK. So it's such a fundamental question where the answer is such a non-specific answer, but for a week, right.
So next is from Dr. Ajit Kaur. Complications of autoimmune disorders like arthritis of various joints, resistant UTI due to autoimmune disorders, why? So that was the same question which I had. I think
The way I look at it, that some of the drugs, not all of them, they do suppress the immune system to some extent. And some of the drugs that we use, especially like cyclophosphamide, azathioprine, and mycophenolate mofetil or rituximab, they can suppress, that's why they're called immunosuppressives. On the other hand, there are drugs like hydroxychloroquine, methotrexate, sulfasalazine. They are not immunosuppressives. But in case we are using because of the clinical situation, these immunosuppressive drugs, then the person has increased chance of infection. And among the common infections, UTI is probably the commonest. And that's how you can explain that UTI will occur in such a case. The second being the respiratory infection and pneumonitis. So there we have at least the vaccines for pneumonia, and we can control that. For UTI, you will have to just ask the patient to drink plenty of water, not get dehydrated, and then you hope for the best.
But there was an interesting phenomenon. Sometimes what we diagnose as UTI can be WBCs in urine of lupus, and given, and the
So-
fever ongoing.
That is the important point, very important point that you have mentioned, that all the so-called pus cells, I heard the word pus cells, they are actually dead WBC. That doesn't mean that they are all infection. They could be due to some problem in the glomerulus of the kidney. And as Dr. Indrajit Gupta mentioned, in lupus, this can happen. And the sediment is abnormal. So all what is seen or considered as infection may not be infection. It could be involvement of kidney. And so be careful before saying that everything is infection.
Can I just add one thing? That majority of these patients, may be quite elderly. They've got a lot of comorbidities as well. They are not only RA. So the patient may be having diabetes, elderly patient, female patient. So they are also more prone for UTIs anyway. So, the other important thing is that whenever you give the patient any treatment, you should make sure that the treatment duration is optimal. The standard of care, again, giving them some clues, what to do, are very important to try to eliminate the recurrent UTI problem. But yes, when you are using all these drugs, there are going to be increased risk.
So from Dr. G.S. Grewal, if it is not RA but RF test, then the disease should be RD and not RA.
Dr. Grewal, this is an interesting thing. Let me tell you the history. When Noel Rose in New York, upstate New York, in Buffalo, New York, when he tested his secretary, who was suffering from rheumatoid arthritis. And in those days, rheumatoid arthritis, and still today, because the main emphasis of the disease is on the joints, systemic disease is very uncommon, and that therefore it will remain rheumatoid arthritis and not rheumatoid disease. Rheumatoid disease means there is systemic involvement with vasculitis, which is very unusual. So the disease is rheumatoid arthritis, but the rheumatoid factor test, the name was given by Noel Rose. His secretary had rheumatoid arthritis. The factor he determined was in a patient with rheumatoid. So he called it rheumatoid factor, and that's a historic truth. In India, people have put A at their own. No laboratory has ever mentioned is a rheumatoid arthritis factor. It is called rheumatoid factor. But do you know the real name? The real name is antiglobulin factor, because rheumatoid factor is an antibody directed against aggregated FC portion of IgG. So if you come to that, then remove all these terms and call it anti-aggregated IgG-FC antibody.
So next,
Beautiful answer, sir.
yeah, absolutely.
You taught me again.
So next question is from.
I always say rheumatoid factor.
This is also.
Give it the name antiglobulin test.
This is also an interesting one. If RF negative RA patients, is third generation CCP3 antibodies have more prevalent than generation first CCP antibodies? Oh.
This, I think the laboratory person should answer.
It is the specificity in the cases that we are looking in the first generation and the third generation.
Absolutely.
What here it means is that you have a ACPA which is positive, and we all know that ACPA
is
is
specific.
very, very specific for rheumatoid if it is clinically correlated. Even patients who ever had tuberculosis can have an ACPA positive, but then you have to see the patient, understand whether the joints are inflamed. You have ACPA, which is really in high titers, which Professor Malviya said, at least 3 times more than the upper level, just not 14 if it is, say 5 is a cutoff and you are 7.5. You have to be quite, thoughtful about what you are diagnosing it. It should be in a high titers.
What we receive questions from the patients and clinicians is anti-CCP also a prognostic marker?
Yes.
Yes, actually.
The cell can change.
Especially for the erosive, I think.
Yeah.
Erosive.
Even before rheumatoid arthritis is clinically manifested, if the patient is anti-CCP and they underwent say certain test like MRI, they actually showed bone erosion. So that is where it is very important that they are very erosive in nature.
This question is a very interesting and very important question. Rajendra called. I tell you, if you have read New England Journal of Medicine in recent days, the flavor of the season is anti-CAR T cells. These are
Yes.
T cells. They have receptors. They have been changed, modified, and these receptors go after all type of B cells which are creating the havoc there. And you take the cell from the same person, modify the receptor, and re-inject the same cell back in the person, and that will wipe out all the bad B cells which are producing these antibodies. And the good news is that in Mumbai, the Tata Cancer Research Institute has started doing specific CAR T cell treatment, but it is in lakhs and lakhs of rupees. So it is at an experimental level, but in Germany, they will call you if you have the money. It will cost about 20 lakh rupees. You go there, they will take your blood sample, they will change this receptor of the T cells of your own. Then they will proliferate that T cell, re-inject back in you. And if you by chance have this disease, that you will get cured of it. So what you are saying is going to be true. Whether I will be alive to see that or not, I'm an old man, but I am very delighted to give you this news.
So this happened with the scleroderma patient that they have used in CAR T,
Yes.
and they could.
All autoimmune diseases, CAR T cell therapy is going to be miraculous.
Even myositis.
And now off-the-shelf CAR T cells are available. So you don't have to go, you have just to order, but you have to have a lot of money for
So
that.
Chitra Bansal, what is the difference between actually B27 and RA?
Oh, I mean, this is like asking what is the difference between gorilla and human beings. They are different species. One is autoinflammatory syndrome and the other one is autoimmune syndrome. In autoinflammatory, there is the innate immune system is abnormal, and that then causes problem in the HLA class 1 molecule related diseases they are. While rheumatoid arthritis is autoimmune inflammatory, where antibodies are formed and they are involved in the pathogenesis. So you are talking of two entirely separate species of disease.
Another interesting question from Ravi, how to explain the increased susceptibility of phototoxicity in lupus?
That is indeed.
Yeah, it is quite interesting that the majority of the patient with lupus will have all sorts of skin manifestation, be it urticaria, be it photosensitivity, be it other forms of different things. Even drug-related allergies will be more commonly seen. Well, it is the way your lupus patient's skin is that, as soon as you go in the sun, there will be obviously inflammatory response due to the UV rays and your cells within. And that will then cause degeneration. And then, the basic fundamental will be the same. Like, the patient's inflammation has to be triggered on, and it has to go unopposed by different mechanisms. So, yes.
Good evening. In the market today, multiple ELISA kits are available for ANA screening. The number of antigen tested by these kits vary. Which antigens are relevant and necessary to be tested? So I think ELISA, although we say that it is not a gold standard test for screening of ANA immunofluorescence being, but we are using 4th generation. I think ELISA kits are now available, which are very sensitive, very specific also. And I think, and more importantly, when we are using 4th generation ELISA kit, it is the instrument which also matters, that if we are using an automated processor or an automated ELISA reader, I think it will be better and the results will be much superior as compared to the manual one, if we are using a 1st generation kit or a manual processor.
I would like to add here that it's all very good to do these very sensitive tests, but please remember, don't order ANA tests unless you have gone through the detailed history. And as Dr. Agarwal has already mentioned, unless you have fairly strong evidence on the history and physical examination that the patient is likely to have systemic lupus, only then order the test. Because as I mentioned, some of these tests are positive in normal people up to the extent of 30%. So if you indiscriminately order these tests, you will be stuck with a patient who is a normal person crying because you have shown that the patient is ANA positive, which is a false positive.
So another question, I think this is a repeat one.
Repeat question.
No, this is a repeat.
So importance of ANA positivity disease, how to differentiate from lupus nephritis?
I don't know. I think Kikuchi I always consider part of SLE.
Yeah.
So it is a nomenclature that, it stays on, but if you follow the patients of Kikuchi, invariably, over a period of time, they turn into lupus.
And the good treatment is available if you give them, early hit with your dressing. But, it is quite satisfying to treat the patient with Kikuchi early.
So Neha Mittal asks, can dsDNA antibody becomes negative in a patient initially negative at the diagnosis before the start? So this will we discussed. So Neha, as a laboratory person, what I have seen is I have not seen dsDNA becoming negative post-treatment. I have seen few cases coming out to be equivocal. That means they were positive in high titers, coming out to be equivocal, not negative. But what clinicians?
So, for example, Neha's question is a valid question. You did a test, dsDNA, which was initially negative. And you had a clinical manifestation of, say, musculoskeletal, and you were treating with, say, very low dose steroid, hydroxychloroquine, probably because that's how the disease was presenting. But over a period of time, the disease changed its course. And then you have a now lupus nephritis coming up, and that's where the dsDNA has started, because it's quite, goes hand in hand with lupus nephritis. So major organ is now getting involved, your dsDNA has started coming positive. So these are the things that can, this progression may high.
So what is the percentage of patients getting automatically cured from resistant UTI while having autoimmune disorder? And in the
If you have a patient who is getting complicated UTI, I'm just framing the word complicated UTI, you need to go back to your urologist, get relevant tests done. They may be having a fistula or they may be having other conditions. Get them treated for a prolonged period of time, because you need to keep the person off, these infection, as well as you treat the basic disease, which is autoimmune.
I would like to say that I have been in this field for more than 55 years. And I have treated probably more lupus than many in India and other autoimmune diseases. But UTI has never been a problem. Is it being confused? Because in these diseases, often kidney is involved and they have microscopic abnormalities. That is not UTI. That's the activity in the kidney itself. And you have to then do the kidney biopsy to find out whether the autoimmune disease is affecting the kidney itself, rather than to call it as UTI. Please be careful about that.
Yeah, then other very important thing is the lab error, collection error.
Yes.
Very important.
Absolutely.
Because you see, recently I had a patient, who was saying, lots of UTI over. You ask them, you got any symptoms, then it is not. Then, again, you send it to a different lab, and then you think, oh, well, that is not.
I think this UTI business, there is something grossly wrong. Why don't we see it?
Right. So any more questions, Rahul? Yeah.
Right. No, we can move. We have.
I think we can move on that. We have a discussion on that already. Any more questions? So if there are, no more questions. So I would like to thank all the eminent panelists. Thank you, Malviya sir. Thank you, Dr. Indrajit. Thank you, Dr. Pandey, and thank you, Shubha. So we need to conclude this panel discussion. And there were, I think, maybe more than 100, 150 about audience which has joined. So see you soon, and we'd like to have some more discussion in future. Thank you.
Thank you.
Thank you so much.